All right, let's talk about something that makes every resident's heart skip a beat. That critical lab page for an elevated lactate. You know the one. For any student or resident on the wards, having a really solid go-to framework for this isn't just nice to have, it's absolutely essential. So let's build that framework right now. Okay, picture this. You get that page, you pull up the labs, and there it is. Before your brain starts spinning in a million different directions, what's the one single question you need to ask yourself to get started? Well, this whole explainer is designed to give you a step-by-step approach to nail that question every single time. So here's our game plan. We're going to start with the biggest, most important fork in the road, distinguishing type A from type B lactic acidosis. Then we'll dive deep into those classic perfusion problems of type A. After that, we'll explore the wild world of cellular problems in type B, looking at everything from systemic diseases to common drugs and toxins. And we'll wrap up with a really interesting special case, one that's super easy to miss if you're not looking for it. Look at this slide. Seriously, this is the entire mental model you need. Just burn this into your brain. Type A is a delivery problem. The oxygen just isn't getting to the tissues. Maybe the roads are blocked. Type B is a factory problem. The oxygen delivery truck shows up, but the factory, the cell's mitochondria, is broken and can't use the supplies. Delivery versus factory. If you can master this one distinction, you are already halfway home. So let's keep things off with type A. This is all about tissue hypoperfusion, and clinically this is the one you really worry about, being immediately life-threatening. It basically means your patient is in some form of shock and their cells are literally suffocating. And the cause is here? They're the big pillars of critical care, right? We're talking hypovolemia, maybe from a massive bleed, or just severe dehydration. We're talking cardiac failure, where the pump itself just isn't working, sepsis, with all that vasodilation, and of course the ultimate state of no perfusion, cardiac arrest. All of these roads lead to the same destination. The oxygen delivery system has failed. And this is what that patient so often looks like at the bedside. You'll see the classic signs of shock. Their blood pressure is low, their skin is cool and clammy because their body's shunting all the blood to the vital organs. They're not making much urine because the kidneys aren't getting perfused. And they're confused as the brain starts to feel it too. This is the picture of a type A lactic acidosis. But, and this is a huge but, here is a crucial clinical pearl. We are all trained to look for that cold, clammy patient. But you have to remember that in early septic shock, all that massive vasodilation can actually make the patient's skin feel warm and flushed. It's a classic trap. So don't let warm skin fool you if everything else is pointing towards shock. Okay, let's pivot now to type B. So the oxygen delivery is fine. The truck made it. But the cell itself, the factory, just can't do its job of aerobic metabolism. The factory's offline. And as you're about to see, the reasons for this are way more diverse, usually having to do with an underlying disease or some kind of direct mitochondrial poison. So what kind of diseases can cause this factory problem? Well, diabetes is a big one, especially in diabetic ketoacidosis, or DKA. And DKA is kind of tricky because the severe dehydration can cause a type A problem, but there's also a type B component from messed up cellular metabolism. Cancers, especially really aggressive ones like leukemia and lymphoma, can cause a pure type B acidosis. And with HIV, yeah, patients are at higher risk for sepsis, that's type A. But some of the medications themselves can directly poison the mitochondria, which is a pure type B problem. And sticking with our factory problem, we have got to talk about drugs and toxins. This category is so important because these causes are often reversible, but only if you spot them. The first thing you should do is a super careful review of the patient's med list. Metformin is the one everyone knows, right? It's the textbook example, especially when the kidneys aren't working well. But look at this list. So many of these are common ICU meds that act like direct mitochondrial poisons. Antiretrovirals for HIV, the antibiotic linezolid, the sedative propofol, they can all shut down the factory. And then you have drugs like epinephrine or beta agonists like albuterol for asthma that do something a little different. They don't poison the mitochondria, they just ramp up glycolysis so much that they overwhelm the system and you end up with a ton of excess lactate. And of course, we can't forget about alcohol. The biochemistry here is really the key. When your body breaks down alcohol, it creates this massive flood of a molecule called NADH. And this flood of NADH basically causes a huge metabolic traffic jam. With nowhere else to go, the cell is forced to shunt pyruvate down a one-way street, turning it into lactate. All right, now for our final category, which is a true medical zebra, D-lactic acidosis. This is such a fascinating diagnosis because, one, the lactate isn't even made by human cells, and two, this is the critical part, your standard lab test won't even pick it up. You have to know to go looking for it. So who gets this? You need to have a really high suspicion in a very specific type of patient. The classic case is someone with short bowel syndrome, or another major cause of GI malabsorption. If you see that in the patient's chart, your D-lactate alarm bells should be going off. The way this happens is pretty unique. In a patient who has that altered gut anatomy, a big load of undigested carbs can make it all the way down to the colon. And when it gets there, the gut bacteria just have an absolute feast. They ferment those carbs and, as a byproduct, they produce D-lactic acid, which then gets absorbed right into the bloodstream. Now, what makes this so different are the symptoms. Instead of that sick, shocky patient you see in type A, D-lactic acidosis presents with really prominent and often kind of bizarre neurologic symptoms. We're talking confusion, weakness, and ataxia, that profound difficulty with coordination and balance. It's all about the brain. This right here is the single most important thing to know about this diagnosis. If you have a patient with short bowel syndrome and some unexplained neurologic weirdness, you have to specifically order a D-lactate level. The standard lab test only measures L-lactate, the kind our bodies make. You will 100% miss this diagnosis if you don't ask for the specific test. So let's bring it all home with one final thought, a scenario you will definitely face. You've got a patient in shock, you're pouring in fluids, you're starting pressors, you are fixing the type A delivery problem, but their lactate is just stubbornly high, or maybe it's even climbing. What does that tell you? It tells you it's time to pivot. It's time to stop chasing the delivery problem and start investigating the other pathway. It's time to go hunting for a type B factory problem. And that is the power of using this framework at the bedside.